So I'm delighted to introduce our next speaker, who is Dr. Annmarie Burns. And Annmarie is a consultant clinical neuropsychologist with the charity Brainkind. And Annmarie, so your talk, Too Many to Count, Brain Injury in the Context of Domestic Abuse.
Thanks, Jess. So before I start, I'm just going to give a bit of context regarding domestic abuse. It's predominantly, but not exclusively, a gender-based crime. And back in 2021, the WHO raised that so many women worldwide were likely to experience it during their lifetime that it really was an urgent public health priority. We also know that people from minoritized groups and backgrounds are disproportionately affected by DA, and I think that's something we need to hold in mind throughout all of this talk. And it's largely a hidden crime which goes unreported. These people are not presenting to hospital in the way that some of the other groups that we've heard about today are. Just want to kind of highlight here this last statistic that the prevalence of domestic abuse in England equates to a call to the police about domestic violence about every 40 seconds. And for me, this really highlights what a high priority, high volume crime this is. So just coming back to this point about how some groups are disproportionately affected, we know that women from Black and minoritized groups are at a much higher rate of repeat victimization. We know that they face additional barriers in terms of reporting abuse, seeking help, and receiving that support as well. And it's important just to reflect on things like if you have insecure immigration status, why you might have some very real fears about sharing your data with police, with healthcare systems. And I'm not going to go through all of these other groups, but I do just want to highlight older people. We know that they're very much underrepresented in DA services, despite the fact that research shows that they probably experience domestic abuse at similar rates. And when we look at common causes of brain injury, one of them is falls, and it's often falls in older groups. So I think it's really important, again, just to consider that and think about there might be other reasons just than a trip as to why someone might experience a fall. So for women, one of the main causes of acquired brain injury is domestic abuse. And again, when we look at women's brain injuries, falls come up quite frequently. And I think that's sometimes something that needs a bit of further explanation. So this is a quote from one of our research participants, and it was actually the quote that we took Too Many to Count from the title of our report, which we released last January. And for me, I came into this research at the point that we were starting to collect data. And I hadn't really understood the context of extreme violence that these women experience day to day. And this quote really, for me, sums up what the nature of their experience is. These women haven't just experienced one or two blows to the head. They've often experienced it many, many times. So what we did in our research was that we had 60 participants across a range of host sites in England and Wales. They were all community-based sites. Some were people living in their own homes, but some of the women were also living in refuges. We had a really good age range, but the majority of our participants did fall in the kind of 30 to 50 years bracket. And all our participants identified as female women. We didn't actually exclude anyone, but these were the participants that came forward. And we assessed them on a range of measures. We used the Rivermead Post-Concussion Questionnaire, the Brain Injury Screening Index. We also used the CHAT, which is an American-based head injury assessment tool specifically for domestic abuse. And then we used some mood measures, the PHQ, the GAD, and the IES for trauma. And I think that, and we also use the dimensions of anger rating scale, but actually I'll talk about that a bit later. In terms of our ethnicity of our participants, we had really good representation across a number of ethnic groups. And these are our key findings. So we found that approximately half of our participants screened positive for a history that was suggestive of brain injury. Large numbers were reporting a serious blow to the head, but I think what's interesting here and what's worth reflecting on is this research was co-produced with survivors of domestic abuse. So at the point that we were designing the study, we had several focus groups. And lots of the people in the focus group said that they really didn't identify with the term strangulation, that if they were asked that, they wouldn't acknowledge that that was their experience. And so it was because of those conversations that we included a question about being held in a way that they felt they couldn't breathe. And interestingly, 75% of the participants endorsed that. So there's something interesting there around language and how we ask questions, because if we simply asked about non-fatal strangulation, we're likely to miss a group of people who have potentially experienced hypoxic brain injury. So these are the results from the CHAT, which is the head injury assessment tool from Ohio, which is designed specifically for domestic abuse populations. And you can see that this matches on to the results of the Brain Injury Screening Index, with similar numbers of participants endorsing being hit on the head and also being held in a way that they couldn't breathe. In terms of our other measures, the majority of participants, unsurprisingly, given the situations which they were experiencing, were reporting moderate to severe symptoms across the PHQ in terms of low mood, the GAD-7 in terms of anxiety, and also on the IES measuring post-traumatic stress. They also had moderate to severe levels of post-concussion symptoms as measured by the Rivermead, but I think as several talks today have illustrated, those symptoms heavily overlap with depression, anxiety, trauma. So we wanted to have a look and see whether the people who screened positive for a brain injury were more likely to be experiencing moderate to severe symptoms. And we found that that was the case. So the people who screened positive for a history suggestive of brain injury were more likely to fall into the moderate to severe range for post-concussion symptoms. Similar finding, again, for low mood. Interestingly, we didn't find it for anxiety. People who screened positive and negative for a history suggestive of brain injury, equally likely to experience moderate to severe levels of anxiety. But again, that finding that the people who screened positive for a history suggestive of brain injury were more likely to fall into the probable to significant range for trauma symptoms as measured on the IES. I mentioned earlier that we use the depression of anger rating scale. Interestingly, all of our participants rated very low on that, and I think there are a couple of reasons for that. One, I think there are some issues around the social acceptability for women of acknowledging that they experience anger, but I think particularly for this group, where many of them are wanting their stories to be believed, it might not feel safe to be acknowledging that they too experience anger at certain times. And in fact, we've done another study in the with women in the criminal justice system where we found a similar thing, that the women just aren't endorsing feelings of anger. So I think we probably need to think about that a bit differently. So the Brain Injury Screening Index, which was developed for use in the criminal justice system to screen people to see if they're likely to have a history suggestive of brain injury, also asks about some cognitive symptoms. And you can see here that, again, our participants are endorsing memory and concentration. Now, as has already been discussed this morning, those symptoms overlap with other mental health and physical health illnesses. So what I think is actually more interesting is that a third of our participants were reporting difficulties with speech. Now, unfortunately, we don't ask about that in any more detail, but difficulties with language obviously are associated with brain injury, and it would be really interesting, I think, in future studies to explore that in a bit more detail. So, of course, there are limitations to our study. We had a relatively small sample size. It's entirely based on self-report. We didn't have any access to people's medical records to corroborate our findings around women's brain injury histories. And the other thing I think it's really important to mention is that both the recruiters and the participants knew that this was a study about brain injury. So the recruiters were likely to be predisposed to select people that they thought might have had a brain injury, and equally participants might have been more likely to be people concerned that they had experienced one. We are just embarking on some research with Women's Aid, where every person who accesses their services is being asked some questions about brain injury and non-fatal strangulation specifically. And interestingly, the rates look lower, and that's a much bigger sample. So I think it's going to be interesting to compare those findings with a much broader population. So moving on to think a little bit about non-fatal strangulation. This quote, I think, is very powerful. Again, it's one of our research participants, and she gives a really clear account of what's happening when your brain is being starved of oxygen and blood flow. There's increased understanding of the danger and prevalence of non-fatal strangulation, and it was in the press yesterday, some of you might have seen. We know that there's some very serious long-term consequences related to hypoxic injuries, and these injuries, such as things like strokes, don't always happen immediately, and they might happen in the days or even weeks following the incident, and so people might not always be making that connection. And I think it's interesting, the previous talk was talking about how people put their symptoms onto that incident of a head injury. I think in this population, one of the things that I've noticed is actually they're not attributing their symptoms to the head injury. So many things have happened since. They're actually much more likely to be attributing their symptoms to other things like trauma, mood, and a whole range of different things. I would highly recommend people take a look at the IFAS website. They've developed some acute emergency guidelines around recommendations for how people should be assessed if they go to A&E. But I know that they are also producing some community guidelines, and Helen Bishard, who's another neuropsychologist, has done some excellent work with them. But their website has really great, very accessible information, so highly recommend that. So just thinking about non-fatal strangulation and anoxia, we know that fairly quickly damage starts to occur within the brain when people are deprived of oxygen. And we know that the hippocampus and prefrontal cortex are particularly susceptible. And so things like working memory, episodic memory are quite likely to be affected. And it's really important to think about the different symptoms that people might be experiencing in the context of this kind of brain injury versus a brain injury via a blow to the head. Anoxic brain injuries have been explored in other contexts, but I think they're much less well explored in the context of non-fatal strangulation. And there's a recent paper which kind of discusses this emphasis on loss of consciousness and a failure to kind of acknowledge also the importance of amnesia, loss of memory in this context. So I think it's really important that when we are asking people about these experiences, we do ask about a range of symptoms. And we are currently trying to expand our brain injury screening index to ask about the different symptoms associated with non-fatal strangulation. Thinking about the broader research, our work mirrors that out there internationally. There's been lots of work in North America, Canada, Australia. Eve Valera and her colleagues have been done lots of work in this area. Commonly reported in terms of cognitive difficulties and memory and executive functioning difficulties. And it's quite straightforward to think about the impact that is likely to have on someone who is in a domestically abusive situation. If you're not able to plan, if you struggle with issues regarding memory, it's going to be really even more difficult to get out of that situation. And then they're likely to be at even more risk of domestic abuse and potentially even brain injury. We've done some other research, as I mentioned earlier, with women in the criminal justice system, and one of the things that has come through really strongly in that research is that, again, very high levels of potential brain injury in the context of domestic abuse, but these women also have very high rates of a range of other physical and mental health difficulties, things like FND, fibromyalgia, asthma, all very commonly reported. And of course, we have to acknowledge the presence of substance misuse for many of the people in these situations. So there are lots of barriers for women in this context seeking and pursuing a brain injury diagnosis. Just listening to some of the talks that have happened this morning, I know that our research participants are not even getting to those conversations with doctors. Now, for one thing, they may still be in the abusive relationship and they may be being prevented from attending hospital or GP appointments. And even if they do go, they may go with the perpetrator and not be able to discuss things freely. Something that came out very strongly, both during the research, but also when we spoke to the women afterwards and fed back our findings, is that they have very limited awareness of the potential seriousness of a head injury because they live in this context of such extreme violence. Often when you ask the question, have you ever experienced a serious blow to the head, they say, oh no, I've not experienced that. When you say, have you ever lost consciousness, that will then trigger a whole series of experiences they've had. So what I consider a serious blow to the head isn't necessarily what they would consider a serious blow to the head. They've also often had very bad experience of seeking support from statutory services. And this is where I think we need to link back to those original slides where I highlighted that people from minoritized groups are often disproportionately affected by these issues, but we also know that they often are denied access to healthcare, that it isn't equitable. So we really need to hold all of these things in mind. The women also raised, and I think this is something we all have to think about very carefully when we're undertaking these assessments with people, concerns about what would happen if they were diagnosed with a brain injury. What would this mean in terms of their parenting? What would this mean in terms of any kind of custody hearings or family court procedures that were going on? And they often spoke of being advised by their solicitors to not go and ask for support with mental health problems, for not going to their doctors to explore issues around head injuries, for fear that that would then be on their medical records and could be used by the perpetrator to discredit either their witness statements, to undermine their abilities to parent. So as a neuropsychologist, I'm thinking, well, there's also the risk of going through a court system when you don't understand the procedures, where there's quite complex decisions that you have to make, and if you have got a brain injury and you have got cognitive difficulties, you should be receiving the correct support. But we have to acknowledge that their concerns are realistic and important, and we need to hold them in mind. And there was a study done in Canada, quite a small qualitative study, where they asked solicitors, if you were defending the perpetrator, would you use information about brain injury against the victim? And the majority of the solicitors acknowledged that it probably wasn't the morally right thing to do, but that is what they would do. So just interesting to hold that as well. Another quote from a participant, and what I think about when I read this quote is, if this participant went to her GP and reported that she was having these memory difficulties, would brain injury be in their differential diagnosis? I think probably not. Probably the initial things that would be being considered are trauma, anxiety, depression. And so it's really important that we raise awareness that for women in this situation, or for anyone experiencing domestic abuse, brain injury does need to be considered. And there are examples. One of our participants, she actually had a formal diagnosis of a brain injury, but she had gone to her GP repeatedly over a period of 5 years. She was actually quite convinced she had Alzheimer's. Her mother had Alzheimer's, and that's the reason she thought she was experiencing memory problems. But it really was a long journey for her to get the correct support. So in terms of next steps, as a charity, we continue to raise awareness of the potential of brain injury in the context of domestic abuse. We think it's important that we raise awareness across the whole system so that everybody is aware that this is a potential issue, but also that we support those who are living in domestic abuse situations to understand the importance of seeking medical support if they do experience a head injury, and also so that they understand the symptoms and are better able to advocate for themselves. In terms of all of us here in this room, I think it's really important that we're aware of our own biases and assumptions. I think a lot of the people that I've met in the course of this study, they're not the kind of people that would normally get included in brain injury studies. And I know that when I first came to this research, I was quite skeptical, and I didn't really understand the context of extreme violence that people are living with. So it's really important that we consider that. It's also important to remember that not every head injury does result in a brain injury, but that these women, these people, they deserve the opportunity to have that explored. And finally, just thinking about holding on to that idea around that there are wider implications, thinking about things like the court and the potential implications for women if we do diagnose brain injury. And finally, just to say, because if we don't continue to raise awareness of these issues, there is a likelihood that brain injury symptoms continue to be misattributed and that brain injuries go undiagnosed for these women. We know that broadly within brain injury, if people don't receive the correct support, they're likely to become more financially vulnerable, more socially isolated, and these are risks for domestic abuse as well. And so we create this sort of vicious cycle of brain injury and domestic abuse. And of course, there are significant health, economic, and social repercussions of this. And that's the end. Thank you.
Thank you. Do we have questions for Annmarie? So Laura at the back.
That was an interesting talk. I was surprised that you didn't make any mention of prevention. Does your organisation do anything to sort of lobby for intervention to prevent men from hitting women in the head?
I mean, I think there are lots of charities already doing that, actually, and Brainkind is predominantly a brain injury charity. I think Women's Aid, Changing Lives, Safer Lives, there's a lot of charities working in that space. But yes, obviously, prevention is much better.
And a question right at the back in the corner.
Hi, sorry. I think, saying about biases, I actually think, sorry to come at it from a different perspective, I think one of the gaps in the way we frame neuropsychiatric issues is around domestic violence. So I work in TBI and Huntington's, and I see, certainly not every patient, but I see a lot of irritability and aggression emerging in those populations, and so a lot of that can be targeted at carers and loved ones and spouses. And I've had a lot of success recently in involving domestic violence support workers and agencies when I'm managing irritability and aggression in neuropsychiatric cases. And I think it is maybe a bias of all of us not to think about aggression in that home context as domestic violence, even when it's occurring in neuropsychiatric patients. So it's just more of a comment. But
yeah, no, I think that's very relevant. Thank you.
For an excellent talk, for the BPNA for putting on this talk. I think it's really important to be included in the day. I'm a consultant perinatal psychiatrist, and we know this is a big part of our community practice, and that violence against women increases during pregnancy and after having a baby. I'm just thinking back to one of the slides that Dr. Alan Carson presented earlier, thinking about the trajectory of TBI through the lifetime, and there's a little peak after babies are born in the early years. I was just wondering, is there any research that you know of that links TBI in this population, so women suffering domestic violence, and also their children?
I'm not aware of that, although one of the things that we did ask about was, in fact, whether the women had experienced adverse childhood events like potential childhood brain injuries, and they do report very high levels of that as well. I mean, certainly, if there is violence in the home, then the children are likely to be exposed to it. And I think, again, this thing of, you know, if children are trying to intervene, then there is a risk that they fall, or, you know, there's lots of different aspects to it. I think there is research, but I personally am not familiar with it. But I'll go away and have a look now. Thank you.
And a question from Rich in row D.
Thanks. I gave a talk on TBI to Women's Aid and some of the people who were working there, and there was a real kind of, they're really keen to kind of get involved in screening and also using the needs index as well to identify how they can help. But at the same time, do you think that could also potentially open up a real kind of can of worms in the context of symptoms potentially being contributed to from PTSD and substance misuse, and actually the picture could end up being so much more complex than shelter workers being the initial points of screening for this, and because people represent healthcare or research, and how do you think that could be improved in terms of other clinical workers being based in shelters to help clarify?
Yeah, I mean, we don't want to go round diagnosing everyone with a brain injury when they don't have one. That's really unhelpful. And I think it is really important to reiterate this point that every head injury does not result in a brain injury. Otherwise, we create a lot of anxiety as well. I think the sector is really interested, and I think that's because they see so much of it and it's been so neglected. I think there's a lot of education to be doing with them. I mean, I've worked lots with Women's Aid, and they're always saying, can we get scans? Can we get scans? And again, trying to sort of move away from that idea that that's necessarily the right approach. I think it's about educating domestic abuse organisations to be able to have these conversations with the survivors of domestic abuse, such that they can then advocate for themselves and go to the doctors and go to their healthcare provider and just describe their symptoms in the right way. Because I think with this cohort, they're not linking it back to the incidence of a head injury or the incident of non-fatal strangulation. And so I don't think they're always reporting their symptoms in a helpful way. So I think that's the angle I go from. I'm not sure it's the perfect way, and I think we're all sort of slightly feeling our way in this field. But it's great to hear that you've been working with them as well.
Okay, thank you very much to Annmarie and to everybody for the very interesting discussion.